Some stories don't leave you, not because they were loud, dramatic, or catastrophic, but because they were quiet, intentional, final. Sand still lingers. It was a Thursday. I remember that because I was on the second of 312s. We were short a tech, as usual, and I'd picked up a float nurse from step down to help manage beds 4 and 5. ICU can hold up to 14 in our unit. Private rooms, sliding glass doors, full monitoring on the wall, and remote telemetry to our central station. But that day we were holding at 12, and I was covering 4. Room 8 got the call out at 8:17. Trauma, middle-aged male, blunt force, MVA, hit and run, side impact on the driver's side. EMS did great work in the field. Secured airway, bilateral IVs, pressure maintained. He coded once on the way in, but they got him back. By the time he rolled into our unit, we already had respiratory ready, trauma attending en route, and I had the MAR and chart open. His name was Darnell, mid-40s. No significant history outside hypertension, and elevated a 1C, alert, oriented, talking. That's what made it strange. You don't usually get that kind of clarity in a trauma this bad. But there he was, cracked ribs, fractured pelvis, bruised lung, and still he was cracking jokes with the trauma team as we worked. "Y'all better not let me leave here in a bag," he said, with a grin. We chuckled, just a little. You learn in ICU to let patients lead the emotional tone. If they're joking, you joke back. If they cry, you don't force cheer. We mirror, not manage. Vitals were stable, for the most part. HR in the 90s. BP 134/78s. Sat 96% on 4L. Neuro intact. We got a femoral central line placed, and started fluids. His pelvis was stabilized. C-spine cleared. Neuro scans were clean. The team decided on non-op management, unless things declined. I got him settled. Started the drips. Updated the board. Logged his pressure points. Checked orders. He'd be due for dressing change at the femoral site in an hour, and ortho was planning a review in the evening. Then he asked to use the phone. Not a big deal. Happens all the time. We sanitize it between uses and monitor duration, to make sure they're not overstimulated. But Darnell wasn't calling for conversation. He was saying goodbye. First his daughter, then his brother, then his mom. Each time he told them, clearly, just in case. "I just want you to know I love you. This ain't me giving up. Just covering all bases." It wasn't dramatic. No tears, no ominous music. He was steady, not scared, not paranoid, just resolved. He even turned to me, smiled, and said, "I feel good, nurse, real good. I just got this feeling though. So I wanted to say it." You don't argue with that. I told him we appreciated how cooperative he'd been, how stable he was looking. I said I'd be back in 20 for dressing change and some meds. He gave me a thumbs up and asked for ice chips. At 10:31, I returned with a tech for the dressing change. Everything was standard. Sterile field set up, gloves on, patient alert, talking. I exposed the site. No sign of infection. Minimal drainage. BP was 120/80 seconds. No signs of distress. Then it happened. No gasp. No clutching of the chest. Just silence. He stopped speaking mid-sentence. I looked up, and his gaze had frozen, mid-blink. "Darnell," I said, stepping closer. No response. HR dropped to 40. Then 20. Flatline. We called a code. RT was already outside the door. Compression started within seconds. Crash cart in. Epinephrine pushed. Intubation attempted, but we already had airway. Nothing obstructed. ACLS protocol followed to the letter. We worked for 27 minutes. No return of spontaneous circulation. No electrical activity. He was gone. TOD, 11:02 a.m. The trauma attending stood in the corner for a moment, silent, then quietly said, "He knew." I stayed behind after we called it. Cleaned him, recovered the lines, redressed what needed dressing, bagged personal effects. I left the phone where it was, still warm from his hand. When I called the daughter, she didn't cry. She just said, "He told me." I didn't want to believe him, but he knew. That's what stays with me. Not the code, not the monitor alarm, but that quiet hour in between, the peace, the laughter, the phone calls, the way he took time, the way he gave it away. In ICU we fight, we stabilize, we chart, we watch, but sometimes, they just know. And when they do, all we can do is make sure their final hour is met with dignity, truth, and someone who listens. He wasn't alone, and I think he needed us to see that part. Not the panic, not the end, but the goodbye. Hello friends, and thank you so much for tuning in. A special shout out to our incredible subscribers. Your support keeps these creepy, fascinating, and sometimes even comforting stories alive. But here's something to think about. Only about 30% of our viewers are subscribed. If you enjoy our content, hitting that subscribe button helps more than you might realize. It only takes a second, but it makes a world of difference. While you're at it, a like and share go a long way in keeping these eerie tales coming. Thank you again for being part of this journey. You're the reason we're here. See you in the next one, if you dare. There's a kind of silence that settles in the ICU after 2 a.m. Not quiet, exactly. The monitors still beep, vents still cycle, pumps still tick along with their own metronome. But everything slows, visitors are gone, most patients are sedated or asleep. And we set night shift, learn to operate in a rhythm of hushed voices and soft footsteps. That's when the unit shows its age. The way floor tiles creak when no one's walking, the hum of old HVAC through the ceiling vents, the occasional flicker, not of light, but of doubt. I've worked night shift for 9 years. I don't spook easy. You can't, not in this job. People are vulnerable here. Family members cry, machines fail, bodies fail. You learn to hold your own emotions until you get to the break room or your car. And when it comes to strange things, we usually chalk it up to stress or lack of sleep. But then there was bed 3. We're a level 1 trauma ICU, single rooms, glass doors, full telemetry. We rotate patients depending on acuity. But some rooms carry a weight. Bed 3 became one of those. It started a week after we lost a patient in that room. He was 36, young father, admitted after a sudden cardiac arrest in the grocery store parking lot. No history, no warning signs. Paramedics got a rhythm back, but neuro never recovered. We kept him on support for 4 days. His wife never left the room, not once. The day they withdrew care, she held his hand and read him bedtime stories, said it's what he did for their daughter every night. He passed at 9:12 p.m., peaceful, no complications. We cleaned the room, turned it over, standard protocol. Then the shadow started. It was Morgan, one of our senior night nurses, who mentioned it first. I was giving her report on another patient when she paused, mid-sentence, and glanced down the hall toward bed 3. "You ever see someone standing at the foot of that bed?" she asked. I shook my head. She hesitated. Tall, male-shaped, just for a second, then it's gone. We laughed it off. Night shift fatigue, peripheral vision, maybe even a reflection off the monitor glass. But she wasn't the only one. 2 nights later, Julie, an experienced float nurse from another unit, asked if anyone else saw a guy in dark scrubs standing in bed 3. She thought it was a tech, said he was standing at the foot of the bed, just watching. When she turned fully to speak to him, there was no one there. We reviewed security footage. Nothing. We checked staff sign-ins. No one unaccounted for. We even asked engineering to look into the lighting, see if maybe shadows from the hallway or equipment were casting funny images onto the glass. No explanation. But the stories kept coming. Never threatening, never harmful. Just present. Always at the foot of the bed. Always during the overnight hours. Never when a patient was actively in the room. There's no chart note for that. No protocol to follow. No OSHA guideline for handling a shadow that doesn't exist on paper. But still, we started keeping the curtain half drawn in bed 3 when unoccupied. Not out of fear, out of respect. ICU nurses carry things, not just codes and rhythms and labs. We carry goodbyes that didn't get said. We carry breaths that didn't come back. We carry stories, some of them unfinished. That room, it changed us a little. I don't know what people believe. That's not my job. My job is to care, to advocate, to intervene when necessary, and to comfort when that's all that's left. But I'll tell you this, when I pass bed 3 on night shift now, empty, dimly lit, just the hum of equipment in the air, I don't rush. Sometimes I pause, just for a second, and I say quietly, "He's sleeping now. She'll be here soon to tuck him in." I don't know if anything hears it, but it feels right. There's a rhythm to ICU work that most people don't see. Our shifts aren't just 12 hours on paper. They're 12 hours of watching, anticipating, reacting, documenting. Every blink, every breath, every beep. But we track it all. You don't last long here unless you learn 2 things. 1. How to stay calm under pressure. 2. How to pay attention to things no one else does. This happened about a year ago in our surgical ICU. I was charge nurse that night. We had a manageable census, 9 out of 12 beds full, 3 vented, 2 fresh post-ops, and a handful of stable cases. I'd done my rounds, checked that staff had their assignments, verified the central monitor logs, and made sure meds and labs were on track. Room 6 was quiet. A 68-year-old female patient, Ms. Reeves, recovering from a bowel resection. No complications, no sedation. Vitals were stable, pain well controlled with PCA. She was alert and oriented, just anxious, didn't sleep well, kept saying hospitals made her feel lonely at night. We'd offered to move her closer to the nurse's station, but she declined. "I like the quiet," she said. So we left her in room 6, with a soft hallway light, and the call bell clipped to her gown. The next morning during handoff, I went in to check on her personally before end of shift. She smiled and said, "Please thank the nurse who sat with me all night." I blinked. "What nurse?" I asked. She looked at me, confused. "The one in the blue scrubs, young woman, had her hair in braids. She sat in the chair by the window and held my hand, while I dozed off. Said she'd keep watch until I felt safe." I paused. There was no nurse assigned to room 6 overnight. The monitor tech had her on central view. She never called out, no clinical needs. I double-checked the assignment sheet. No floaters, no students, no techs sent into that room. And none of our nurses had braids. I asked gently, "Did she say her name?" Miss Reeves shook her head. "No, just said I reminded her of her grandmother. Sweet girl, warm hands." Later that morning I reviewed the hallway security footage, not out of suspicion, but just to verify. No one entered or exited room 6, between 22:30 and 5:15. Not even to check vitals. That bothered me. Not in a fearful way, but in a professional one. Even when patients are stable, we still do visual rounds. Even if they don't remember, we're still in and out of those rooms. Always. I brought it up at huddle that night. Half the team chuckled. One nurse said, "Maybe it was a dream." Another said, "She probably saw a nurse earlier and remembered it differently." But then Paige, another night nurse, spoke up. She said, "This isn't the first time someone's described her." I turned to her. "What do you mean?" Paige nodded slowly. "About a year ago, I had a patient in room 6 who swore someone sat with her after her husband passed. Same description, blue scrubs, braided hair, said she was calm, didn't speak much, just held her hand. It wasn't any of us. We pulled records. 2 other nurses recalled similar comments from elderly patients in that same room. Same nurse, same description. Always during the night, never on the roster. We don't have an explanation. We've never tried to force one. There's nothing harmful about it. No trauma, no medical event. Just comfort, just presence. In ICU, we do our best to provide that. But we're human. We get pulled in 5 directions. And sometimes, someone else shows up when we can't. I'm not here to say what's real or what isn't. I'm just telling you this. If you ever find yourself in a hospital bed too anxious to sleep, and someone sits beside you, holds your hand, and tells you it's going to be okay, ask for her name. We've been trying to learn it for a while now. There are things that only get talked about after hours. When the lights are low, when the unit slows down, when the code carts are at rest, and the break room is quiet, nurses have their own way of telling stories. Flat-toned, factual, emotionally filtered. Not because we're cold, but because we've learned how to carry what others can't. This one came from a family member, and it wasn't the kind of thing we chart, but I still remember every word. It was 3 winters ago. ICU was full. We'd had 2 transfers in from the AD, both post-code, one intubated, the other comfort care. Our team was split between criticals and end-of-life support. I was assigned to rooms 1, 2, and 4. My colleague Diana had 3 and 5. Room 3 held a woman in her early 70s, late-stage metastatic cancer. She'd been in and out of the hospital for months. This time she wasn't leaving. Her daughter, maybe late 30s, had flown in from California. She'd been sleeping in the pull-out chair beside her mother every night. Kind, quiet. The kind who refilled her own coffee and folded up the blankets before shift change. We do what we can for families like that. Extra warm blankets, gentle check-ins, a little space. We'd set the recliner up near the window and offered earplugs and eye mask, but she always declined. Said she wanted to be awake if her mom needed her. That night, Her mother's breathing had changed. Shallow, irregular, gurgling. The kind of pattern that ICU nurses know all too well. We call it the death rattle, though we don't say that to families. We just explain that the body is beginning to slow down. She was a full DNR, no machines, just morphine, Ativan, and comfort measures. Around 2:40 I did a routine check on the IV. The daughter was awake, sitting upright, just staring toward the door. "Everything okay?" I asked. She nodded, but looked off, pale, like she'd just come in from the cold. I thought maybe she was in shock, or sleep deprived. We see that a lot. Then she said something I didn't expect. "I just saw someone walk out of this room." I paused. "You mean one of the staff?" She shook her head, slowly. "No, a man. In a hospital gown. Thin, pale. Hair looked wet. He came out of the corner right there." She pointed near the far side of the bed, where the wall meets the mobile IV pole. "He looked at me, didn't say anything, then walked straight into the linen closet." I turned toward the hallway. Linen closet was across from room 3, small metal door, badge access only. No way in, without a staff card. She looked at me, still calm, still level. "I'm not crazy," she said. "He didn't feel bad. He just looked tired." I didn't argue, didn't laugh, didn't try to explain it away. I just nodded and asked, "Would you like some tea or water?" She smiled a little. "No, I think I'm okay now." At 4:17 her mother passed. Peacefully, no distress, just exhaled, and didn't take another breath. We followed protocol: time of death, notification, charting, body care. The daughter stayed until the transport team arrived. She helped us wash her mom's hands, thanked us all. When she was leaving, she turned back to me and said, "I think he came to walk her out." And that's all she said. We don't document those moments. We don't report them to administration. But we remember. I've been in this field long enough to know how the body fails, how pain builds, how we ease it. I've watched vitals drop to 0 more times than I can count. But sometimes, there's more happening in a room than monitors can measure. I don't need to explain it. I just need to show up, be there, hold space, because maybe, just maybe, someone else does the rest.
Thank you so much for watching. Your support means everything and keeps these stories alive. If you enjoyed this video, consider subscribing. It really helps the channel grow, and I'd love to hear your thoughts, so drop a comment below, give it a like, and share it with someone who loves a good eerie tale. Thanks again for being here. You make all of this possible.